Hello, everyone. Thank you for coming. Welcome to NAUTO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendees screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAUTO's Executive Director. Norm, the stage is yours.
Thank you, Erica. I'm pleased to welcome you all to our first of the breakout sessions. This session is titled Governance and Privacy, Data Problems and Solutions, and the moderator and organizer is Leanne Candura from HSRI. So let's go ahead and bring Leanne to the stage. Hey, Leanne, how are you doing?
Great, how are you, Norm?
Fantastic. I'm going to turn the time over to you to introduce our first presenter.
Wonderful, thank you. So as Norm just said, I'm Leanne Candura. I'm a Vice President at Human Services Research Institute and Director of our Population Health Team and serve on the NATO board. I'm the moderator for today's session on governance and privacy, data problems and solutions. And I'm excited to bring you 3 presentations that touch on this important topic. HSRI is a mission-driven nonprofit that focuses on changing systems that change lives. Experts at HSRI have been involved in building, managing, analyzing, and integrating hospital and all-payer claims data for over 10 years and know the importance of identifying and solving data problems to ensure high-quality data for the important work of improving health, healthcare, and social service systems. We hope to make today's session as interactive as possible. Each presentation is about 10 minutes long. Please use the chat feature throughout the presentation to ask any questions along the way. We'll have about 5 minutes of Q&A after each session, and then maybe some more time at the end with all of the presenters. So now let's welcome our first presenters on stage, Nicole Karlsson and Jennifer Howley with the New Hampshire Department of Health and Human Services. Welcome.
Hi, my name is Nicole Karlsson. I'm a public health data scientist with the New Hampshire Division of Public Health Services, and I'm here with Jennifer Howley, who is our hospital discharge data coordinator. And we're here to talk about our efforts to better capture work-related illness in hospital discharge data. This work is done to improve occupational health surveillance, which is about using data to understand and prevent illness and injury from the work environment. In order to do that, we need good data that captures the entire working population and doesn't differentially leave people out. This kind of surveillance is often done using workers' compensation as a payer to identify cases. So I want to take you through a quick conceptual model to understand how we go from work injury to the counting of a workers' compensation visit. The first step is that the patient recognizes that it's work-related. Does it have a clear connection to work? The next step is that it needs to be recognized by the healthcare system. Is the hospital asking, is a patient feeling safe reporting? And this feeling of security will be different across different vulnerable populations. Then from there, it needs to be assigned to workers' compensation as a payer. Is the patient actually covered by workers' compensation? This varies by state, but in our state, for example, self-employed or sole proprietorships are not required to be covered by workers' compensation. You can see that these may be particularly vulnerable or have a different distribution of work-related illness and injury. It also has to be actually paid by workers' compensation, because what we see in our data is not what coverage the patient claims, but what's the coverage that actually paid? So if workers' comp decides this is not a covered incident, we're not going to see that. And then finally on our end, is our analysis recognizing that this is workers' compensation? We don't get a flag in our data from the hospital saying this is workers' comp. So we need to do somewhat complex analysis to recognize which payers are workers' comp payers. And it's not always clear. So on our project, we looked at the New Hampshire hospital discharge data set, focusing on all emergency department visits from 2016 to 2022. This includes data from all 26 New Hampshire acute care hospitals, plus visits in our neighboring states of Maine and Massachusetts. So what are the fields that we looked at? Of course, workers' compensation. We looked at occurrence code 4, which records the date for a work-related accident, condition code 2, which is when the patient says that something in the work environment caused this visit, patient relationship code 20 as an employee, and work-specific ICD-10 codes Y99.0, civilian activity for pay, and 99.1, which is a military equivalent, Z57, including its subcodes, and ZL4.2. We found 4 findings that I'm going to present today. First one is that, yes, adding these variables notably increased our work-related visit count overall. When we looked at the cases that we thought were work-related by including all the indicators we mentioned, 23% of them did not have workers' compensation listed as a payer. And this varied by state. As you can see, our out-of-state data only had 8% non-workers' comp, but in-state, a full 25% of the work-related cases did not have workers' comp as payer. Although here, I should note that we do not get some of these indicators from out of state due to data sharing agreements, condition codes, and occurrence code. We also saw geographic variation of county of residence of the patient. If you see this map on the side here, some of our more rural counties in the North Country, and then out west here, where we have 29% of their cases without a workers' compensation payer. At the bottom here, we have our anonymized hospitals plus OOS, which stands for out of state, on the x-axis. And on the y-axis, you have what percent of the work-related cases had workers' comp as payer. You can see some variation, but for the most part, it is fairly stable across here. But then you see something over here, we notice like Hospital T, which wasn't including workers' compensation as payer at all. So that showed us something that we need to look into because we know they're having work-related cases. So finding number 2 was that Y99.0 and occurrence code in particular were our most important additions. If you look at this table over here on the right, and we're limiting it here to New Hampshire hospitals because of what I said previously about some of the data not being sent from out of state. So when you focus on these New Hampshire hospitals, this table shows what percent of the work-related visits had which indicator in which combinations. And Y99 occurred alone in 10% of these work-related cases, the vast majority of which were 99.0. Occurrence code 4 occurred alone in an additional about 4%. And then condition code here added an additional about 2% alone, which is kind of small, but you're going to see on the next slide why we think it might be useful to include anyway. Patient relationship codes and Z codes occurred very, very rarely without any of the previously named indicators in combination, adding less than 1% total altogether. So as I hinted at on the previous finding, use of indicators varies by hospital. Again, we have the hospitals along the bottom here on our x-axis and the fraction of all work-related illnesses on our y-axis. We've got Y99, occurrence, and condition codes. You can see the different distribution across hospitals here of what percent of the work-related cases have these codes. You see something like Hospital Y here, which really consistently is including all these different indicators for work-relatedness on their visits. Then you have something like Hospital K, which is also pretty consistent, but their consistent is pretty much tending not to use these indicators and never including the condition code. On the other hand, there are hospitals like C and D in the orange here, and they're kind of all over the board. They almost never used Y99 codes. They're in the middle of the range for using the occurrence code 4. And then you have this condition code, which, as you can see, is actually used pretty rarely across all the hospitals. And there's a big number of hospitals that don't use it at all. But it really was pulling its weight here for these 2 hospitals. And that's the reason you might think to include it, even though it's less common. An additional factor here is that hospitals C and D in this case are closely geographically located in the same county. So if we're not including this condition code here for hospitals C and D, that region of the state might be missing a good portion of their work-related cases. And finally, this finding here we want to touch on is how workers' compensation use varied by condition. So you have something like exposure to bodily fluids. Think of something like a needle stick or a bite or something like that. Potentially hazardous bodily fluid exposure. If you're going to the emergency department for that, it's going to be paid by your workers' compensation a good portion of the time. In this case, we see almost 90%. And that Y99 by itself only adds an additional 3%. But then you step down to something that often is also thought of as a traditional work-related health outcome, and that's injuries. Maybe a little more struggle depending on the injury to get paid by workers' compensation, or maybe it's more common in jobs without workers' comp coverage. And that's 76% of those cases that are coming in with workers' comp, and Y99 itself is adding an additional 12% of cases. And then you step down even further to something that's less of what is thought of as a traditional workers' compensation, and that's heat-related illnesses. But heat-related illnesses at work are incredibly important. They're under increasing focus by OSHA right now, and it's really important that we have good data to understand them. And yet, if we're only relying on workers' compensation, we're only seeing 64% of them. And Y99.0 all by itself can add 24% of the work-related cases. So wrapping back up to this conceptual model, revisiting again. Unfortunately, what we're doing here is not able to touch any of these three gates at the top step of this model, but it did get rid of those other three that we had back at the bottom. Does that mean that there are no more barriers entirely? No, we need to watch out for a couple more things. Number one is that the hospitals need to be using these codes, and you saw the inconsistent use across hospitals. And then in analysis, you need to be sure that you have data sharing agreements that are appropriate to receive all the variables. And if we're comparing our results to other states, are they using the same indicators? If we want to compare to ourselves over time, how different is this from what we've done in the past? So our takeaways here is that adding these indicators can absolutely improve occupational surveillance, particularly in vulnerable populations and different geographic areas and different health outcomes. However, we really need to have a better understanding of when and why different hospitals are using each indicator. So we'd love to talk to you more about this work. I've put our email addresses on here, and we would love it if you reached out to us to talk if you're doing similar work or you have an interest in this work. Please reach out anytime, and we really appreciate hearing from you.
Hi, welcome, Nicole and Jennifer. Thank you for sharing this incredible work that you're doing in New Hampshire. I'm really excited for the audience to also weigh in and ask any questions they might have. But while we're waiting for their questions, I have a few of my own. My first is, how do hospitals indicate workers' comp as the payer in the data? So those that you were able to distinguish who the workers' comp payer was, how did that present?
Sure, I'm happy to take this question. So hospitals, especially, or at least for the discharge data, they submit payer name, and that's kind of raw, written out payer name. And they also submit a payer code, which unfortunately isn't consistent from hospital to hospital. So for some hospitals, their payer code might indicate whether it's a workers' comp or a Medicaid or something like that. And then other hospitals, it really doesn't seem to align to any sort of payer type at all. And then for the payer name, we use, if payer name has, is like an insurance company that specializes in workers' comp, we can then identify that as workers' comp. Or if it's the name of like a business, such as like a construction company or a restaurant, then we identify those as workers' comp.
Great. So yeah, I can see that then would be challenging from identifying. So these are just free text fields that you're getting this information on.
Exactly, yes. And with having millions of rows of data each year, trying to match these free text fields is to a payer name is or a payer type is challenging for sure.
Have you done any work with hospitals to help, I guess, help them help you by asking to put more information in those free text fields?
Not at this point, but I think that now that we're digging into this data, I think it's worth a conversation.
Yeah, I can see that as a big challenge. So no questions yet, so I'll just keep going. I have lots of them. Have you looked at using New Hampshire's APCD data to supplement this work? I know New Hampshire has had a long-standing APCD, and I'm just curious if that might help with you trying to understand this issue.
We hope that it could help us. There is a couple challenges we've just started looking at the APCD, and it looks like it may not actually contain workers' comp claims within it. We're not sure about that. And then also our APCD doesn't have a lot of identifiable variables, so linking the discharges to the claims could also be challenging. But it's something that we're starting to explore.
That's great. Well, again, thank you so much. And if people do come up with questions, we'll hopefully have everyone have some time to come back on at the end. But thanks again for sharing this presentation and this important work. So now we're going to welcome our next presenter to the stage, Karen Hampton with the Oregon Health Authority. Welcome.
Good morning or afternoon, depending on your longitude. My name is Karen Hampton. I work for the Oregon Health Authority on the All Payer, All Claims program, which is Oregon's APCD. Thank you for allowing me to talk to you today about the quality of summary data. How can you know? So why collect summary data? Clearly, I have several reasons listed, but I think two callouts are resourcing to receive non-summary data, certainly ingestion and storage, but primarily staff time to produce usable data, and the usefulness of the summary data for your purposes. It's always hard to know whether to start with use of the data or end with it, but in this case, I recommend starting with it. What do you need to know, and at what granularity is the data needed for those uses? I'm not going to talk about our payment arrangement file, but I wanted to acknowledge this as a major source of experience for me and to share some basic information. My agenda includes submitters from the beginning, how to set up summary data for success, validating the data, publishing, and activities for recurring quality improvement. Involve the submitters in the design and be prepared to share use cases. What do we want to do with the data received? This is the start of a shared understanding of terms and the support needed that informs every other step. This does not mean accept no from submitters. I expect we've all heard data is simply not available, only to have some reporters submit the data without issue. But understand what is behind the no. Is it trade secret concerns? Is the data held in a different part of the organization not previously involved in reporting, or is it something else? Setting up for success is broken into major effort at the start and continuing efforts on the next slide. Again, I'm focused on the limitation of summary data in that various people are using various systems to answer a question with a number. No caveats, no notes. So I'm largely focused on ways to promote comparability, which needs people to do the same thing the same way in different places and different systems. Clarity moves forward in documentation, definitions, instructions, frequently asked questions, and various tools. Surprisingly, the most frequent definition question I hear is, what do you mean by other? Listen to what's behind the questions that are asked. Use active participants for early review of tool concepts before a large effort is used to develop something that might miss the need. There are things we need data submitters to know, even if they think they don't need to know them, and there are things we need to know from data submitters. As in all activities, communication is essential, and less frequent submission increases communication needs. I don't expect there are any surprises on this slide, but it is important to keep communication needs near the front of the line at all times. There's a lot of information on the slide, but there are two callouts. Training. Submission is mandatory. Knowing what you're doing is voluntary. Staff turnover, as either internal moves or out of the organization happen. We cannot assume the person building the data or transferring the file is the same person as last year. So trainings each time is essential. Reminder emails. Yes, apparently multi-billion-dollar industries frequently don't maintain a calendar of their legal needs and rely on staff performing those tasks to track and share the needs. That person left and we didn't know is our most common reason for late submission. I encourage emails to be sent broadly, including any business lead and compliance officer contacts. Most of my slides and time are spent in setting up the system, and I think that's realistic. But once you have the data, do you trust it? Summary data does require more creative data validation, although even the basics like does it total are useful. Using Oregon's PATH file as an example, Validations of the file are done at 4 points. Before data is submitted, our Excel-based tool allows submitters to see contract dollar totals, the highest payment methodology for the contract, how much was spent on primary care, etc., if we can get them to look at the information available in the tool. When files are received, they are checked for file completeness and format for successful loading. All data and other criteria must be within the file or compared to a companion control file received in the same submission. This is where we first check the math and use the control file, or header and trailer rows, of course. Then at data processing, after the first year, we can do comparisons to past years. And from the start, we can do comparisons to state averages. For example, the total dollars spent, the primary care spending, and any per member per month calculations. Finally, after data is loaded for analytic use, does the data make sense? This is the eyes-on review and a frequent point that we discover there are errors in the data. But all of that, other than some validations that compare to averages by line of business, is about the data that came from the submitter now or previously. What else is available for validation? Other sources could be loadable for automated review or might be part of the eyes-on review, depending on the timeliness of availability, the ability to load the data, and the thresholds needed for comparison. Even with those limitations, comparing to other data sources can identify gross outliers and get data replaced more quickly. This can include the total number of members reported to our insurance division in their enrollment reports, or data from claims. It's only a ballpark comparison, but if our claims data shows a higher total paid than the payment arrangement file, we know there's a question to ask. And then in Oregon, our Medicaid organizations report similar information much earlier in the year, and we can see how far off that estimate is from the data reported to us later in the year. This isn't available everywhere, but they are examples of asking around for resources. I want to take just a moment to highlight Oregon's Excel template tool. I suppose as a warning that if you build it, they won't always come. There are 5 worksheets, and I'll do a flyby on 2 of them, data and summary calculations. This slide shows example data on 3 contracts, which we know from the unique contract IDs under PR APM 003. In this portion, the reporter has data on each row for who the contract is with, the type of provider, line of business, payment model, dates of service, payment for primary care, and total payments. This slide shows calculations on the data worksheet. The template converts the contract start and end dates because payments that started prior to the current reporting period or end after will be prorated for the calendar year reported. In this example, it's only a year contract, so prorating isn't needed. But I want to draw attention to the last 2 columns. Even before submitting the file to APAC, a reporter can see what APAC will consider the most advanced payment category at the contract level, so rolled up if more than one payment methodology is used in the contract, and how many unique contracts we see. The next worksheet in the template has summary calculations. I'm showing 2 of them. On this slide, the reporter can see that for their commercial line of business, and line of business is shown directly above the blue box, out of the $101,000 spent, all of it is fee-for-service category or category 1. For the Medicare Advantage line of business, it's category 3B. So on the data input sheet, the requester can see the category at the contract level. On this page, they see it at the line of business level. Finally, an example of primary care payments. Oregon has specific expectations for all insurers, not only Medicaid, on primary care spending. If the requester wants to know how their data looks, they can use this section of the summary calculation worksheet to see that no primary care spending was reported for the commercial line of business contracts, while 20% of the spending for Medicare Advantage is reported as primary care. If this surprises them, they can review the data worksheet to see where the errors are prior to submitting the data. A late but standard quality check is to put the data out and see who objects. We have often experienced this as the first time reporters look at their data, even with a tool that performs many of the calculations prior to data submission. The first time some see the data is after publication. Know what you want to do with late feedback. In Oregon, we're required to produce reports. Does the agency want to bear the full burden through delayed publication for poor data quality or call out those who produce the poor quality. We have varied from year to year. With the problems and needs I've described, clearly Oregon APAC isn't done with assuring quality in our summary data. The value of our Excel template is greatly underutilized. The level of effort for the data submitters is not spread out throughout the year as it could be. And a general continuous activity on our side is always needed. So my summary on summary data. Start with discussing the needs with submitters, create a full range of tools, look for creative comparisons, and ask about discrepancies rather than assuming an error, but ask. Push for adequate resources on all sides. We often complain in order to get adequate time assigned, not because the submitter staff aren't doing a good job, but because they need approval to spend the time. Have a communication plan and use it. Thank you for allowing me to present today.
Hi, Karen.
Hi.
Thank you. That was a very interesting presentation on how to overcome some of these challenges with data quality. And I'm really happy that our audience has come to us with some questions. So I'm going to start with some questions that have come in. First is, how can we validate the integrity of any data source?
And that is one of the cruxes of anything, not just summary data. And we sort of assume that if they're giving it to us in fragments that it's more reliable, but that isn't necessarily the case. And in Oregon, we technically, under our law, have the authority to do audits. We do not have the resources to go somewhere and do any kind of an audit. So I think that the more that can be built into law, the better it is. And it may be a matter of working with agencies. An example is when we have people ask for a waiver because they say they have fewer than 5,000 covered lives in Oregon. And we go to our Department of Business Services, of Consumer and Business Services, and say, well, your enrollment files say that you have 27,000. And you're telling us you have 1,500. And then they go back on their side and see where the discrepancy is. So using resources like that is helpful. But there is always going to be some trust involved in the data that's submitted.
Great. Thanks, Karen. For those who aren't familiar with the term, what is summary data?
So I think of summary data as essentially pre-processed. People are giving you a conclusion. And that means not only that they are totaling dollar amounts, claim numbers, whatever it may be, but they are applying a common definition to determine what those numbers are. And that's one of the places that we really run into some difficulties. In Oregon, for instance, primary care, we have a very specific listing of the services and the provider types that qualify as primary care. But when we're collecting it at the contract level, it's extremely unlikely that they're contracting at that level of detail. So there's a little bit of a leap of faith in that kind of thing. But I believe summary data is anytime they are drawing conclusions and totaling up independent before the data ever reaches you.
Great. And so you did focus a good portion of your presentation on the payment arrangement files, or the PAF files. Can you talk a little bit about the sources that you're using, the external sources you're using to validate those data, and which ones have been the most valuable?
I think that probably the most reliable for it would be the claims data, because we get some counter information under our rules, even if we're not getting a payment amount. And I'm thinking of capitated payments that have been sent. So we can't compare that in APAC, but we can know that they occurred. And that would be at the insurer level, not at the contract level, not at the provider level, because those don't align between the two different data sources we have. For our CCOs, our coordinated care organizations, which are our Medicaid organizations, attachment L has been, our exhibit L has been really very helpful. It's usually different, but it creates a set of expectations and discussion about why it's different. And it makes it easier to sort of point out the different areas for it. And then simply providing comparing to previous years is also really helpful once you're up and rolling, because it's like, hey, did your business actually drop 20%? Or did you forget to give us some of the contracts? Most often they forgot to give us some contracts. And I'm not sure how that happens, but it does. So.
And how many years have you been collecting the payment arrangement file data?
Since 2017.
Wow. Were you one of the first states to start collecting those type of data?
I wasn't here when they started collecting. I joined that year, but after all the work had been done, I believe we were possibly the second. I know we used a great deal of what Massachusetts had done to set ours up.
Okay. Great. And so since you've been doing that data collection for a number of years now, have you seen an increase in the data quality over the years? Has this allowed you to publish your results more quickly?
I believe publication has not sped up, because we generally do have some people that need to replace their data. And one of the things that we're doing is beginning next year, we're actually going to anticipate needing to process data twice and create some more realistic expectations on the timing. And that's sort of the accommodation of it. I do believe that with the work that we've done, the data quality has improved, but like everything else in the world, we see the things that are wrong. We don't see the things that are working. So most of the things that I raised were problems, but a great many of our data submitters submit high quality data first time. They've got it down. They take it seriously. And we spend our time working on the ones that still need some help.
And I see one of the points you made in your presentation that sometimes it is more challenging with the once a year data collection because, if you're doing it every month, you have more of a chance to have points of communication and sometimes with the annual.
It absolutely is, particularly because we do batch processing. If someone gets new staff for the quarterly files, and 3 months later, you've got a chance to catch up, as it were. But with an annual file, we don't want to wait a year before we can get the data in. So that is more challenging.
Great. So I think we have one last question from the audience for you. Are submitters required to use the same methods when they create summary data?
They are theoretically required to use the same methods, but again, we don't really have a way of auditing it. So we give them the definition of primary care for them to determine those amounts. We give them the land categories, and actually just this past year, we've started sort of as a pilot, a decision tree for which land category does it fall into. So we're continuing to build our resources, trying to firm up as much for the data submitters as for us, whether or not they're going down the right path, because changing the land category is one of the major changes that we see after we have proposed publication. They're like, oh, we misreported the category. So we still need some help there.
Well, thank you so much. Really appreciate you coming and answering some of these questions. And of course, if people have additional ones, we hope to have time at the end to bring everyone back. Thanks, Karen. Now we're going to move on to our final presentation. This is from Ritashree Chakrabarti with GlobalData. Welcome, Rita.
Good afternoon, everyone. I'm Ritashree Chakrabarti. I'm a principal economist at GlobalData. I mainly work in the areas of workforce modeling, strategic planning, and disease cost and management research. I thank you all for attending today's session on governance and privacy, data problems and solutions. Today, I'm going to give an overview to construct a population database using available information from different national and state level data sources. The main reason why we construct this population database is to project future demand of healthcare services and providers based on population projection and other patient level characteristics that are potentially associated with the use of healthcare services. In reality, there is no comprehensive person level data at the state and the sub-state level that has information on demographics and also health conditions that allows us to generate this sort of metrics. And so what we do is that we use a statistical random sampling method to generate a comprehensive representative population sample. And this is a useful tool For health strategic planning to produce forecasts of population, disease, and other workforce metrics. We have used this database in a lot of projects that we have worked with different clients. So for example, we have used this in our previous and ongoing work with HRSA. We have used this with different national professional associations, such as the American Association of Medical Colleges, and also different state-level hospital associations and health departments. In order to build this data sets, we use demographic data that comes from the American Community Survey, or ACS, and also the US Census Bureau that produces county-level aggregate population count on demographics. Health data source, there is a variety of sources. So for example, we use the Behavioral Risk Factor Surveillance System, or the BRFS, for people living in the community, CMS's Medicare Current Beneficiary Survey, or MCBS, for people living in residential care, and a summary of CMS's Nursing Home Minimum Dataset, or NHMDS, for the people in nursing homes. CDC Places is our main data set for county level health data. We start by creating the state representative sample, and that basically merges information from the different sources that I just described using a statistical matching process. So the core microdata on which this population databases are built is the most recent year of the American Community Survey, or the ACS. And the ACS provides information on demographic, socioeconomic characteristics of a representative sample of the population in each state. So the statistical matching algorithm then involves a random sampling with and without replacement to combine patient health information from either the BRFS or the MCBS or the NHMDS file with the larger ACS file that has a representative population in each state. So, for example, the non-institutionalized population in the ACS will be matched with a similar person in the BRFS, and similarly, the institutionalized population will be matched then with a similar person either in the MCBS or the NHMDS file. A match index by strata is developed to sample people across these different files and then combine their information together. And under this approach, some BRFS or NHMDS individuals might be matched multiple times and some might not be matched at all. And the match probability is then dependent on the survey sample weights. Finally, the process will preserve the number of records and also the ACS's sample weights. And this allows to produce a population file for each state with population characteristics representative of that state. The visual here is an example of the process that I described. And really shows how a match between the ACS and the BRFS file works, so that the final data set created at the bottom has key demographic information from the ACS and then matched to a similar person in BRFS using this match index or key, so that we have health-related factors added to our final data set. Now, based on this constructed state population, our next step is to develop the population file at the county level. The US Census Bureau produces data on the aggregate number of people in each county by 5-year age group, sex, and race ethnicity. Using the NCHS urban-rural classification, we can categorize each county as metropolitan or non-metropolitan. And in the constructed preliminary population file, we can also divide the population into metro and non-metro location. Then we reweight sample weights for people identified as metropolitan to match the demographics of the population in each metropolitan county. We also do a similar process with people in non-metropolitan county. And this finally produces a weighted sample for each county that is representative of the demographics in that county. Finally, in the county population file, we calibrate the disease prevalence and lifestyle choices such as obesity and smoking status to match data from external sources. County level estimates of disease prevalence are calibrated at the individual level and then benchmarked to external published information for each county. And as I said, CDC Places is our primary source for external county level statistics used for calibrating prevalence of disease and risk factors in the population file. In summary, the resulting constructed population database then has a representative sample of adults and children in each county by demographics and all these different characteristics. And really the choice of variable that we decide to include in this population file is dependent on the predictors that we use to drive the demand of healthcare services. We can also generate a multi-year database from this population file by reweighting the sample weights and using population projections. And this multi-year database can then be used for forecasting and strategic planning and other health economic research. For example, this population database is utilized to drive forecasts for healthcare services and providers at the state and at the county level. And this is due to the lack of adequate and consistent state level information on those metrics. And therefore, the availability of such a comprehensive data, such as the All Pairs Claim database, can be potentially used in place of this constructed population file to drive workforce forecasting and other health research. So that concludes my presentation for today. And I once again thank you all for attending today's session, and I'll be happy to answer any questions that you might have.
Hi, welcome back. Thank you for sharing your presentation today. I'm really excited to dive into some questions from both the audience and myself on this incredible database that you've created. So thank you. We're going to kick off with the first question from the audience. How confident are you with this probability-based method of matching data from different sources, as it appears you don't have specific PII to do the matching?
Sure, thank you. To start off, when we start the matching, we use the American Community Survey, right? And that is already a representative sample of the US population at the state level. So the way the matching is working, we do not really care about so much about the personal identification, but what we do care is the distribution by the strata. And finally, the matching process, the way we are doing it, the way the algorithm works, it ensures that the number of records and the ACS sample weights are preserved. And that allows us to give a representative population sample at the very end, right? And then when we are doing the county level modeling or county level database, we are consistently benchmarking to information from published sources. So when we are creating this synthetic population at the county level, when you look at the demographics, it would exactly match with the census publishes at the aggregate level. And then in terms of disease calibration, we have this information that is then calibrated to what the CDC is saying. So I think that's kind of the validation we are doing to ensure at the end of the day, it's a representative sample.
Great, thank you. Can you tell us a little more about what was the impetus for creating this database to begin with?
Sure. Yeah. So one of the main reasons we created this representative population file at the target level is that we wanted to look, it's actually a part of a broader healthcare workforce simulation model that we have that allows us to generate forecast of demand for healthcare services and providers. And the idea is we can look at a national data set such as the MEPS, right, that is produced by the AHRQ that allow us to link patient characteristics with their interaction with the healthcare system. So we generate prediction equation based on a national database like MEPS, and we apply this prediction equation on the population file. And that in turn allows us to generate demand for healthcare services using this national prediction equations, but then controlling for local characteristics or sub-state or county level characteristics of the population and then, other circumstances. So it gives us a lot of flexibility when we do modeling, when we want to kind of change individual choices or what's happening in the healthcare system. That was the main reason. And then also the way it's done, it's kind of easy to reweight sample weights and convert this database into a multi-year database. So we can easily generate projections now of population, of disease prevalence, and it can be used as a useful strategic planning tool as well.
Great, thank you. So we do have another question. What biases do you think might exist in the data sources that haven't been accounted for in the synthetic database?
Sure. I think some of the biases that can occur is maybe underrepresentation of a certain group, or what I mean is that some of those socioeconomic characteristics that might not be benchmark. We are benchmarking to the extent that the demographics is benchmarked, but we do not have information on, for example, at a more granular level, maybe zip code level. So things like that can creep up. But in our work, when we are predicting for healthcare services, what we have seen, the main controlling for everything, the main factors are demographics and disease prevalence. So those biases can exist, but it's not so much of a concern in terms of healthcare service prediction, use prediction, or driving demand for healthcare workers.
Great. So we do have an additional question. Have you ever validated the estimates from this population database against counts from state APCDs, for example?
Yeah, that's actually a great question, for some of the projects, yes. So one of the things we do when we work with state hospital associations or departments is we try to get their claims data and kind of try benchmark our model that is based on resident demand against what we are getting from the APCDs. And I'll give you an example. I'm working recently on a project with Hawaii, with the Hawaii Center for Nursing. And for that project, we actually got hospital claims data, and we were able to validate our inpatient days and ED visits compared to what we were getting from the APCD. And actually, they were very, very close. I think for the inpatient days, what the model was spitting out in terms of resident demand, it was almost 99% accuracy. For some states, sure, there might be some differences. For example, with Florida, there could be an influx, for example, tourism or snowbirds, and that is not captured in our model because it's purely based on resident demand. And we used then the APCD to kind of scale and benchmark our estimates.
Great, thank you. We're going to welcome all the presenters back on stage, but I hope our audience still continues to bring in questions for all of the presenters. Thank you. Welcome back, everyone. And I'll open it up also at the end if you have questions for each other. So we did have one question that had come in earlier. It's at the bottom of everyone's screen. I think Nicole and Jennifer, this question was for you. To what extent do the occurrence codes align with the workers' comp payer type? And there's some, specifically the code 4, and occurrence code 24, date of accident, and occurrence code 25, date of last employment.
Sure. So we quickly took a look at the information, and I think that you see workers' compensation and occurrence code occurring together in some sort of combination in about 40, roughly 46% of the cases. Looking back at the data just now, reconstructing this. And we looked only in this case at occurrence code 4, although because we think the other ones shouldn't. Number one, we think the other ones probably are not occurring without occurrence code 4, but you're right, that is something that we should go back and verify actually. And but I also want to touch on a minute why we used occurrence code 4, because this is a particular code of outreach in which someone who formerly worked for our department had worked with our hospital association and reached out to different hospitals and really encouraged them and taught them about the importance of tracking occupational surveillance, and really encouraged them to be using occurrence code 4 in particular. So that was one we really focused on, particularly for our state. I'm not sure if it may be different for other states.
Great, thank you. So again, I'm going to encourage the audience. We have everyone back on stage if there's additional questions for our presenters. I'll keep going with my own, but first I'll ask, do any of my presenters have questions for each other? Okay. No pressure, but if you think of something. So I'm going to go back to the theme of today's presentation, which is data problems in solutions. I want to go through each of our different presenter groups, just asking what is the biggest data problem that you're still working within your own, either within your own state or your own data set that you're trying to solve. And what solution would you love to hear about at next year's conference? Who'd like to go first? I know it's a big question.
I can say one of our struggles for New Hampshire kind of is similar to one of my answers from prior, but it's kind of this, within our discharge data, we see different submissions from different hospitals. Sometimes some of the codes that they use can mean something different, or there's just a lot of inconsistencies. So to see, it's supposed to be this uniform healthcare facility, but it's not as uniform as you would expect it to be. So I'd love some solutions or ideas on making this more consistent from healthcare systems and hospitals. That's our biggest struggle right now.
Great, thanks, Jennifer. Karen or Ritashree?
I think that for myself, it really is a matter of making sure that everyone is applying the same definitions. So anything that we could do, and I think that sort of relates, we receive information as a land category, a HCP land category, and as a number. But I think to really relate to what Jennifer was saying, that's not what the contract group at the insurer see. They've got a bunch of words that they're working from. So it's an open text document completely. So being able to piggyback on what Jennifer said, I think knowing that people are applying things the same way and that they're using the categories, the numbers, et cetera, in the same way would really build confidence in the comparability.
Yeah, and I just wanted to add that, on what I work on, we are ingesting a huge volume of data from different sources. And so the continuity and the uniformity that everyone is talking about is clearly very important. And as we build our models and population files to drive the demand for healthcare services. So I think that's a big theme. Yeah.
Yes, more standards, right?
Yeah.
Key theme. Now, to go back to you, Ritashree, so to your point, you bring in a lot of various large data sets where Where do you see the biggest opportunity for alignment in all of the different data sets? I guess, where is it the messiest right now?
I don't know about the messiest. There are a few things, but to me, the biggest thing is, you know, in an ideal world, if every state had an all-parents claims database and we could pull that in and standardize in a standardized way, then that would be a very, very powerful tool to generate exactly what I am doing, right? Where I'm using something like maps at the national level, creating this population files. So I don't know. So I think just building towards that would be a very, very useful tool. Of course, there will be caveats along the lines of standardizing of data. How do we benchmark the data in terms of, like comparing with each state, right? As we aggregate the data, I think for me that would be the most useful thing to have.
Great. Thank you. So we're about to the end of today's session. I really want to thank all of our presenters for bringing your presentations forward. We wouldn't have a conference without all of the presenters showing the work that they're doing, looking for identifying issues, identifying solutions, and having the opportunity to have these discussions. So I really want to thank each of you, and I hope that we can continue to follow all of the problems and solutions and look for ways to solve them in the future. So I think that's the end of this session. I don't know if Norm's coming back on stage. Oh, look. See?
Sure, why not?
There he is. We talked a lot about the beginning, not much about the end. But.
No, the end's pretty straightforward. Just wanted to thank you all. Thank you, Leanne, for organizing this, and thank you all for your contributions, and especially to our attendees for engaging so much in the chat. That's what really makes these sessions powerful, is when people speak up and say, I have a question or I have a concern, and let us work through those things. And some of those were harder questions than others, but I appreciate that you all were able to take them all. So we do have 2 more concurrent sessions coming up in about 12 minutes or so. So hopefully everybody can join us at one of those concurrent sessions. And thank you all again.